everyone. I think a few other people will probably trickle on, and thanks for putting on your webcam. I just want to go through our agenda briefly. We have a couple announcements, and you should be seeing it projected right now. So the first one is, again, I'm just briefly mentioning that there is going to be third-year funding opportunity application, which we anticipate to be released in the summer of 2020. We're still waiting from ARC for some more additional guidance on the administration and logistics of that, but we did want to let you know that is something that will be forthcoming. Secondly, I sent out an email last week with a request for some information on some miscellaneous items. I tried to make it efficient, so put it in one document for you, but if you could respond to the email and send that to Ingrid, if you could do it by tomorrow, ideally, I'd really appreciate it. Some of those have some time urgency to them. And if you have any questions on the items, you can feel free to reach out to me. Lastly, I just want to mention some webinars that I had brought up in previous emails and just put in a plug for them again. The first is the ARC Learning Health System Leaders Series. Sorry, I'm not sure why that was feeding back. ARC Learning Health System Leaders Series. The first one was actually held last Wednesday, and again, that was something that was born out of the ARC LHS collaborative. So we really encourage everyone to attend if they're able to do that. There was recording that was made, and so I will sure who was able to participate last week, but I will send that out and make that available to folks. And the focus is really exposing scholars to leaders in the LHS space around the country. So it's a great opportunity. Second is the NIH Health System very grand rounds. You're probably aware of that. But again, that laboratory aims to improve and promote collaborative research on pragmatic trials. So again, it's a great resource. This past Friday, Chris, along with some other colleagues, gave a talk, a PCORI-sponsored trial on care worker exposure of hydroxychloroquine. So again, lots of opportunity to hear about current or past trials. So a plug for that, and we can send out invites as we see things that are particularly relevant. I just want to also mention and remind you that our next WIP is on May 4th, and Dawn will be leading that, and I'll send out some preparatory materials and information shortly. Chris, is there anything else you wanted to mention in terms of announcements?
I just a little color commentary. So regarding the third year of funding, it's going to be limited. I think probably there'll be 2 scholarships available for third year of funding. We're still working that out, but if there won't be 5, and we're, as Jeannie said, we will be we're interacting with ARC now about that. But in general, what we are looking for is for this third year. We know things kind of got delayed, but in terms of the startup, but the funding didn't. What we're looking for is individuals who could really benefit from a third year of funding to either complete a project that will have what we would characterize and you would characterize as high impact on the health system. And the health system could be defined as the patient community that you're focused on, your clinical care area, or your whole health institution. But impact would be one, a high impact project. And the second would be that you feel if you had that third year of funding, you could use it to write an individual K award or an individual R award, in other words, to make that transition. And we have both of kind of criteria as possibilities. And I can actually confirm this with ARC, and they really like the idea because we recognize that the pathways that you will take won't necessarily be to independent investigator status, right? Some of you may go that route, and that's fantastic, and that's why we have that one arm for individual K awards or individual R awards. But we also recognize that learning health system scientists may be fully embedded within their institutions and get involved in implementation dissemination implementation within their institutions, improvement within their institutions, and maybe largely funded by their institutions. And that's a very legitimate career path from our perspective. And so that's why we had that second arm. So I just wanted you to start thinking about that. And if you are going to apply, which of those two arms you would apply for. Then lastly, briefly, the Learning Health System Leadership Series is quasi-required. It's only quarterly, and there's a lot of effort that's being put into putting this together. It's designed by the 11 Centers of Excellence, and it's one way that we're coming up with to help you as scholars connect with other scholars at other programs. It's just one way. There are several other things, other opportunities that are going to be coming down the path. So we really want you to attend that one if possible. And then on the collaboratory side, it's just topic by topic. There's just a whole smattering of pragmatic clinical research topics that get presented there, and we wanted to make that available to you. So Jeannie, back to you.
Thanks, Chris. Kate, are you, can I just say, and are you almost ready to go? Oh, no.
It's all good.
Okay. So
okay. Yeah, I literally have three screens. So
okay.
I hope you turn it over to the right screen.
Yes, I think we're good. We're hearing you, and we're seeing you. So let me just say we're really excited to have Dr. Kate Deans with us today, leading our learning session. She's a pediatric surgeon at Nationwide Children's Hospital, Ohio State University, and she's the director of the Center for Surgical Outcomes Research. We're really thrilled for her to be sharing with us about trials and learning health systems today. And in particular, I'm excited about the articles that she selected. One of these articles is a PCORI-sponsored initiative, and PEDSnet was not involved because we're pediatric focused, but a lot of the folks involved in both this paper and then the Distributed Research Network paper are all friends of the PCORNet PEDSnet family. So it's great to be able to learn about this. So with that, Kate, I'll turn it over to you, and maybe you can share a little bit about your own personal research interests and then segue into your talk.
Sounds great. Thank you. So it looks like I'm not looking at you guys, but I am. I just have two screens. So please know that I am making eye contact with my beady little surgical eyes right on you when I ask you questions. So my name is Kate Deans, and I am a pediatric surgeon at Nationwide Children's Hospital. I also run a clinical research center here called the Center for Surgical Outcomes Research. We have about 90 open protocols at any one time. The mission of our group is to decrease suffering in surgical patients, and we methodologically try to get mostly to trials. So our goal is pretty much always to get to some type of interventional study, but we use a wide range of methodologies to get there for hypothesis exploration and generation. So we do HSR, we do some qualitative work, a bunch of different kinds of things. I hear someone typing. I don't know if that's there, but I hear someone typing. So that's what we do here. And then the other half of what I do in my lab job is I run a centralized resource for the Department of Surgery. So we're kind of the methodologic toolbox for the 110 practicing surgeons in our organization. So if they have a clinical observation that they think would make a great research question, they can set up an appointment to see us, and we help them go from clinical observation all the way to their final work product, whether it's a presentation, a manuscript, a grant application, what have you. So we have a good team of people that we surround these surgeons with to get them to feel confident in having a little bit more of an academic practice. So that's what I do. My passion is in clinical trials. I started studying clinical trials roughly 25 years ago, right about there when I was down at the NIH for my research fellowship. And I became heavily involved in a sort of countercultural movement around using fixed treatment protocols to study extremes of care in an RCT design. So many of you might know the ARDS network and the trials that have kind of come in critical care medicine outside of the ARDS network. So we were kind of part of the group that, this is where I learned, kind of sharpened my teeth on clinical trials, was we were part of the group that actually, through the Freedom of Information Act, got all the data through OHARP and then reanalyzed the data to identify that there were some interactions in the data set suggesting that research subjects were dying, and that may have been impacting the p-value that the trials had gotten, and therefore the results and generalization of the studies that were being done in this kind of method. So I love trials. My heart is really on protecting research subjects. You guys are going to see that based on the tone of this discussion. So that's me. I've read all about you guys, and I became reacquainted with your projects and your organizations and where you are in your organizations last night as I went through all your stuff. So I want to start out. I really don't consider this a lecture, okay? I consider this a seminar. And so think of it like your senior seminar in one of your majors in college in the social sciences, where you had 8, 10, 12 people around a table conversing about a topic. I truly believe that we all have insight into everything we're going to talk about today, and that insight is not always based on a strong knowledge base. Sometimes that insight is just because you're a really insightful person. And so I know that I always learn a lot from my trainees, both inside the lab and inside the operating room. And I have learned over the last, probably the last 5 years especially, to listen to my trainees. So I'm sure you guys can all relate a little bit to that. So just a couple things around what we're going to do today, and a couple quotes from my favorite philosopher. In all affairs, the healthy thing now and then to hang a question mark on the things you have long taken for granted. So please, in this conversation and moving out of this conversation, question your dogma, okay? All of our clinical fields and research fields hold a certain kind of dogma, so rules of engagement for them. Question them, and question mine during the course of this conversation we're about to have, so that we can all kind of remain open-minded and engage in some somewhat enthusiastic discourse I think we're going to have. And the second rule of engagement is don't fear to be eccentric in your opinion, for every opinion now accepted was once eccentric. So speak up now, and as you pursue your work and ideas moving forward, embrace the discourse. I can tell you that roughly 12 years ago now, I decided that I wanted to study whether we could treat appendicitis with antibiotics alone and not have to operate on it. And I was booed off many a surgical stage at a national meeting for that. Literally booed, because it is the, it's the money from the appendectomy that powers a lot of surgical groups. So the truth be told, we can treat it non-operatively, but it was an unfavorable opinion. And now here we are in COVID season, and we're trying to protect all our PPE. Nobody wants to operate, and I've received about over 100 emails about how they can use our protocol for non-operative management of appendicitis in some of the hotbed areas. So my point of telling you all that is just, your opinion may seem eccentric, people may shout you down off stages, but keep going with it. Okay, so we have 3 learning objectives today. I'm a pretty organized person. I like to check my boxes. It's how I've been trained. And so we're going to make sure we can check off each of these learning objective boxes. The first is that we're going to understand the definition of a clinical trial according to the NIH, its implications and its applications. And so we're going to talk a lot about that. About a third of our time, at least, is going to be spent on that. The second objective we're going to have is to define and discuss pragmatic clinical trials and their relevance, particularly to LHS research. And we're going to use the adaptable trial to delve into that a little bit, but we're also going to use some other kinds of trials to look at that. I'll tell you, my heart is in pragmatic clinical trials. Just my bias, I think it's the best way of doing things, and I'll explain some reasons why. But we're going to get into that a little bit. Oops, sorry. And then our third learning objective is going to be to define and discuss the strengths and limitations of adaptive trial designs and their suitability to LHS. Now, I try to avoid doing this third learning objective, I will tell you, because adaptive trial designs, although they are conceptually easy, you'll see I have one slide on it where you're going to go, oh, yeah, I could do that. We could do that. Conceptually easy, but operationally very, very challenging, and analytically very, very challenging. And there's a lot of heated debate as to the appropriateness of these types of trials in the trialist world. So I really didn't want to jump into it, but Chris has sort of forced my hand on that kindly, so we will, and we'll talk a little bit about that. I apologize for the adaptive trial article that I sent you. It is heavy, heavy lift reading. I know you can tell it's written by some statisticians, but we'll try to simplify that down to make it a bit easier. Okay, so let's start off here. Let's talk about how the NIH defines a clinical trial, okay? So everything on this presentation is hyperlinked, so if you get a hold of these slides, you're gonna be able to have all these definitions at your fingertips to use them. So I wanna pan through this with you guys. Here is a definition. Let me see if it's showing up my screen. It is, great. So the NIH actually in 2016 came up with sort of a consensus statement and then a set of policies and regulations around what is a clinical trial. And they did this because they wanted to be able to streamline their efforts on evaluating clinical trials and overseeing clinical trials. And so here is their definition as they have outlined it. They define it as a research study in which one or more human subjects are prospectively assigned to one or more interventions, which may include placebo or their control, to evaluate the effects of those interventions on health-related biomedical or behavioral outcomes, okay? So that's how the NIH is defining it. So my question for you right now, and I encourage you, I can't entirely see how many of us are on this call because I only have 6 pictures up in the video gallery, but I'd like to ask you guys, when you see this definition that the NIH put forward, what is surprising to you about it? What does it not include? What does it seem to emphasize? What's surprising to you? Stephanie, what do you think?
You guys hear me?
Yep. And you guys can use the chat function too if you want to use the chat function.
Oh yeah, perfect. What's surprising about the definition itself?
Yeah, what when you read that, just read it over to yourself real quick. What surprises you about it? Does anything surprise you about it? Like, what would you thought of? How would you have thought the NIH would have defined a clinical trial?
I'm a little surprised they include behavioral outcomes. I think of clinical trials as being more like really health related, measurable health outcomes in terms of disease processes or medications or, surgical outcomes in that sense. So that's a little surprising. I think I'm happy to see that it includes behavioral outcomes, but I wouldn't have expected that.
Okay, Erica, are you on the call?
Sorry, I was muted. I am.
Oh, good. So what do you think about that? Are you surprised that behavioral outcomes are included here? Or are you happy they're included?
I'm definitely happy they're included. I agree that I think typically when we think of clinical trials, we're often thinking about more, like comparing different doses of medications, for example. But no, I mean, I guess I'm not overly surprised by that, and I'm glad to see that it's given equal weight to biomedical in the definition.
Okay. What do you guys think about this idea? This was surprising to me. I'll highlight it. Oh, I can't highlight it. The one or more human subjects, where it says in which one or more human subjects. So you can have a clinical trial of one? Really? Anybody know about a clinical trial of one, what those are called? Suchita? Any idea?
Oh, this is the chip trial. Yeah, I was just thinking about those scenarios where you might have some investigational drugs for like a new indication or something like that. So that was one thing that came to mind.
Yeah, I think, there's this trial, it's called an N of 1 trial. Okay, it's a special kind of trial. It's the kind of thing that we all practice in our clinical practices every day, right? We try a patient on something. We look, did it work? Did it not work? Okay, maybe we pull it off. We try something else. Did it work or did it not work? So there are these N of 1 trials that actually have pretty strong research methodology behind them, and they exist. So I was actually surprised in this definition that they said one or more human subjects. So N of 1 clinical trials is included as a clinical trial to the NIH. What do you guys think about prospectively assigned? Does that imply any kind of process to you that might happen in a clinical trial? Because I can only see 6 of you, and I'm not going to call on Jean, he, and Don. I'm going to look at my little cheat sheet with all your pictures. So, Theta, are you here from Seattle, Dr. Ong?
Hi. Yeah, I am.
Hi. What do you think about that, prospectively assigned? When you think of a clinical trial and the term prospectively assigned, what does that typically imply in your mind?
I think it's in the absence of historical controls, perhaps. I mean, I'm trying to think about what it's trying to distinguish itself from in using certain kinds of data.
Yeah, okay. So think about when you are doing a clinical trial and you need to assign someone a treatment. Are you doing that? Are you going, yeah, John, I like you. I'm going to give you this treatment. And Sam, I don't like you so much. I'm going to put you in the control group. How are you assigning therapy? What's that process?
I think it speaks to 2 things. One is, it's asking you to randomize in some capacity or implying it without actually stating it. And then
There
the other
you
issue
go.
is if it's not actually bringing in any kind of the aspect of the patient perspective too. So, you know, we're doing all these co-production things now, and I don't see where that's part of this assigned factor in that input.
Yeah. Okay. Good. So it doesn't say randomized, right? It doesn't say a clinical trial is a randomized controlled trial, right? It doesn't say that. It says prospectively assigned. You're right. So there's no historical control group in this definition, but it doesn't say randomization. So that was something that was a little surprising to me, because when I think of the NIH and how they're going to evaluate a clinical trial, say on a grant application, I always think they assume that the randomized controlled trial is the gold standard. And with such a broad definition, especially around how treatment is being assigned in the trial, it sends this very subtle message of, hey, you know, we're going to fund things that don't have to be randomized controlled trials. And so they just have a much broader definition of what includes what a clinical trial means. Okay, so let me go back to this. Let's go back to the NIH website here. Okay, I want one of you, are any of you doing a trial in your project? I was not able to decipher that from the names of your projects. Are any of you doing a trial right now? Okay, let's go through and let's just put in our adaptable trial, since we all read about it, okay? The NIH has a decision tool right here. This is the decision tool. And you're able to use it to ascertain if the research project that you're doing or that you're proposing actually is a clinical trial. And I know this seems kindergarten-y, like what we're talking about right now, but trust me, it's not. This is important, okay? So we're going to launch this tool and see how it works. And let's do it on the adaptable study. See if I can get to launch. Perfect. Let me pan down here. Okay, so you just walk through it. So let's see. You know, Jeannie, I'm going to make you do this with me because I can see you. Does the adaptable trial involve human participants? Yes, right? You can give me thumbs up if you want. Good, so it does. Okay. Are the participants prospectively assigned to an intervention? Yeah, I see you guys all nodding. Yes, yes, right? So they're randomized. Okay. Is the study designed to evaluate the effect of an intervention on the participants? What's their outcome that they're looking for? Right? They're looking at cardiac morbidity, right? So yes. Okay, next. Is the effect that will be evaluated a health-related biomedical behavioral outcome? Yes, it is. Okay. Are you considering applying? This is not trying to get information about you. So let's just say no, adaptable doesn't need funding because it just doesn't, which we all know is obviously false. Okay. Doesn't really matter how you answer those studies. And so you get these results. The NIH considers your study to be a clinical trial. I don't think any of us are surprised by that. Is anybody surprised about that? If you are, kind of raise your hand or shout out. Yeah, no one's surprised by it. Okay, so let's go back now. Melissa, I think you're here. Melissa, are you in charge of quality improvement in the cardiac ICU? Is that one of your, great. Do you have any quality improvement work that's at the patient level, like making sure kids are on feeding protocols or antibiotic stewardship or anything like that? Can you describe one of those for us? Just one easy one you know a lot about.
So for the feeding protocol, for example, it's based on surgical lesion, so single ventricle versus two ventricle, and it kind of prescribes to the provider how to ramp up feeds with signs of what clinical feeding intolerance would look like to adjust that.
Okay,
and we look at percentage. Oh, go ahead. Sorry.
No, go ahead, please.
I was saying from like the quality improvement perspective, you want to see if we're really following that. What are the barriers to following that? Is it patient related? Is it provider related? And then adjusting the protocol accordingly.
Okay. And what are the outcomes you're measuring, patient level outcomes you're measuring in that?
So looking at it from, want to know like time to initiation of enteral feeds. So when are we starting them? Time to full enteral feeds. When is the patient no longer getting TPN, for example? Time to full PO feeds, so making sure that are we able to get to a place of not going home with an NG tube or a surgical G tube. And then looking at balancing measures such as development of medical necrotizing enterocolitis or surgical neck.
Okay, so based on everything we just heard, Stephanie, everything that Melissa just talked about in her study, does her quality improvement study involve human participants?
Yes.
Okay. Are the participants prospectively assigned to an intervention?
They're assigned based on their physiology. So I guess in that sense, but they're not, it doesn't sound like they're randomized based on the day of the week they're admitted or when their surgery date is or anything like that.
Right. Yeah, right. But they are assigned to something,
Mhm.
right? They're assigned to the feeding protocol, right? Because
Yeah.
that's what they're trying to improve, the kids' nutrition and time to total enteral autonomy. Okay. So yes. All right. Is the study designed, is her quality improvement study designed to evaluate the effect of the intervention on the participants?
Yes. So they're looking at the effect of being on a feeding protocol versus not.
Yep.
With the intervention being the feeding protocol.
Yes. And so is the effect that will be evaluated a health-related, biomedical, or behavioral outcome?
Yes.
Yes, it is. Okay. Well, I don't think she's going to apply for money for this one. So I'm going to say no. Although it is a very, very important, oops, sorry. It's a very important question that we all need to do in our CIs. And it's not, she's not doing this. So here we go. Oh my gosh, Melissa, your quality improvement project is a clinical trial.
Amazing.
Did you know that?
No, I just thought it was mere quality improvement work.
Okay, so now when we think about this, okay, so you keep in the back of your mind, guys, quality improvement versus clinical trial. We just went through two very kind of different examples or things that we conceptually put in different buckets and how we do things in the hospital setting when we're doing research. So one of the things that's interesting is, why did the NIH do some of this stuff? Okay, well, when they wanted to decide if something's a clinical trial or not, it basically allowed them to do a bunch of things. Look, clinical trial requirements. So if you want funding and you meet the definition for a clinical trial, there are going to be requirements around how to present, write up your grant application, of course, and then conduct that trial. Okay, there's going to be specific review criteria associated to what you write. And there's some other things around reporting and clinical practice and human subjects, okay, and how you have to manage human subjects in a clinical trial. So now I want to go back, and this is where we're going to get a little feisty, I think. Hopefully Don's going to speak up. He can get feisty with me. Here we go. So, so what did we learn from this decision tool?
Do I have some sort of reputation as being feisty? Can't imagine.
No. What did you guys learn about this decision tool? What surprises you about it?
I would say how broadly it can be applied.
How broadly it can be applied. So when you get someone like me who's like a little bit of a purist on trials, and I say something like, quality improvement is not a clinical trial. It's not even clinical research. You can take me right to this website and be like, oh, Dr. Deans, but you're wrong. Because when we pop this all through, federal government actually considers what we're doing as a clinical trial. Okay, so if your quality improvement, Melissa, if your quality improvement project is considered to be a clinical trial, what does that imply in terms of implementing the study? Now, I know you're probably not doing this, but what does it imply about what you might need to be doing to operationalize it in your organization?
I mean, it almost sounds like this is like clinical care could meet this definition. You know, somebody's admitted with a fever and I don't know why, so I'm going to do a bunch of stuff and see what happens and try to figure it out. That is a clinical trial by this definition, right?
So, but okay. Yes, I think you're probably right. I think it's reasonable to say something like that. But are you doing it as a research study? What's your intention in clinical practice?
Yeah, so I guess there you go. Well, I mean, I don't know, like, am I going to write it up? Is what I do learn from my is my own learning research, you know, I don't know.
Yeah, I think that's a really good point. So let's get a little tangential on that. Is this Charles?
Yeah.
The only man in the group? It's good. Okay. So I know it's you because it's man's voice, because I can't see your video right now. Okay, so let's go down that rabbit hole. So you decide, you're a nephrologist, right, Charles? You're a nephrologist, aren't you? Okay. You decide that, you know what, tacrolimus isn't very good. You don't like it. So you're just going to stop using it. Okay. And in the back of your mind, you're thinking, yeah, I could report on this. You know, I could probably report on this if my hypothesis, what I'm putting in what I'm saying in my brain is true. I could do that. Okay, I'm going to stop prescribing tacrolimus. And then, you know, a year down the road, you have 15 patients who didn't get tacrolimus and they had a lower rate of infections. Okay, and you've decided that you think it's related to the tacrolimus, and so you're going to write that up and submit it to a journal. What do you need to do before you do that?
Submit to the IRB to do the
submit it to the IRB, right? So once you take a patient and you take them from the patient role into the research participant role, you put them in a category of needing to get protection through a monitoring board, which right now is called the IRB in most of our organizations, right? So let's back it up now. Let's come out of that rabbit hole and talk about Melissa's quality improvement project. Why are those cute little blue single ventricle babies not research subjects when they are in fact in a clinical trial? Anybody?
I think it goes back to the purpose of the project and whether it's designed to contribute to generalizable knowledge. I mean, that might be one reason.
Okay. Yeah, I think that's a good reason. And a lot of people will say we're doing this for institutional processes. We want to make sure our single ventricle babies become enterally autonomous before they have stage 2 or whatever, you know, whatever the thing is. So we need to do that in our institution. Okay, I think that makes a lot of sense. And so now you put this feeding protocol in place, and guess what? You have gotten your single ventricles enterally, and I know this will never happen because I am the GI surgeon for the single ventricle team here. You have gotten your single ventricle babies enterally autonomous by 4 months of age, 100% enterally autonomous. Okay, and 20% less use of G tubes now. What are you going to do with that information? You're just going to keep it at your organization and just pat yourself on the back that you did a good job?
It seems like we should share this. I mean, we could make this generalizable knowledge, I think.
There you go. I agree. We need to share this. And so some of the ways we share it is now by reporting it, right? So your quality improvement project that perhaps, I don't know how it is at all your organizations, did not need to go through an IRB process is now reported in the literature. So those patients were research subjects. True or false?
True.
Yeah, it's makes you think, doesn't it? It's very, very confusing. So let me put it in here. So what is the purpose of the IRB, guys?
To protect human participants.
Great. And most of us should have an IRB site that we can go to from our organizations that tells us the exact mission of our IRB. And I'm going to show it to you right here. The purpose of the Nationwide Children's IRB is to review and provide oversight of all research involving human subjects. So for our quality improvement projects, if we deem them as quality improvement, they don't go to the IRB. So do any of you have to submit all quality improvement project proposals through your IRB?
This is Erica. We have research determinations that have to be done, and the IRB determines whether it meets the definition of human subjects research. So it's not a full application, but it is some type of submission.
So they're involved in the process a little bit.
Yes.
Okay. And so what's the key thing that we need to think about when we're doing human subjects research, when we're doing clinical trials? What is the IRB? What is one of the major things the IRB cares about? Can we just do research willy-nilly whenever we want to?
No.
No. Right? What do we need to tell patients? What do we need to do with patients? Stephanie, what do we need to do?
For research subjects, generally get their consent and tell them what your plan is.
Yeah, informed consent. Informed consent. So are we getting informed consent from the single ventricle families by putting them on an accelerated feeding protocol?
No, we're not.
No, we're not. Do we need to be? Kathleen, what do you think? Dr. Chiodos, do we need to be putting these families, getting informed consent from them to put them on a feeding protocol?
I would say no, because I think the intention is to improve and standardize clinical care across the unit. I also think, like, if the provider who's writing the feeding orders doesn't think that's appropriate or want to do it, they're not assigned to have to do it that way.
Mm-hmm.
So I think it's the intention to kind of improve and standardize care, you know, in the provider discretion. That makes to me it more like quality improvement and more like improving clinical care than like research.
Okay. So does that mean you're not going to publish it?
No.
Okay. So then how are you going to be able to publish it if you don't have IRB? Because a lot of times you have to have an IRB number, or you have to say you've received institutional IRB. How are you going to publish it without it?
Yeah, I guess it depends on the institution and the type of report that you're publishing. I think some journals have the opportunity to publish things as quality improvement works. I agree that this is very gray, but at least to my understanding, and I could be wrong about this, that just the fact that you're publishing it doesn't necessarily mean that it meets the bar for research. You could also publish a quality improvement work. And, you know, again, I think the lines are very, very gray there, but I don't know that a priori, just because you're publishing it, has to be considered research.
Okay, so thank you for being so articulate about that. I think, you know, what people do is when they report the outcomes from their quality improvement work, and I'm talking about patient level quality improvement work very specifically, like the example that Melissa gave us, they do it as a retrospective chart review. So by definition of in most IRBs, doing a retrospective chart review, which is not prospective, it's now retrospective, you can publish without having an IRB application. It can be IRB exempt. So my point in telling you all this, it's kind of confusing, right? And there's a lot, and Kathleen, she said it perfectly, there's a lot of gray here. There's a lot of gray here. So I would just ask you, and Melissa, I'm not picking on you, just you gave such a great example. I just want to use the example. How are serious adverse events reported through quality improvement versus through a clinical trial? Do you guys know? Melissa, do you know what would happen in this protocol? Like, let's just say a baby is on this expedited feeding protocol and they're on it, and oh my gosh, they had this massive aspiration event, and someone decides, maybe one of the nurses or one of the docs of the day says something like, well, we went up too fast on the feeds. We shouldn't have been following the protocol. The kid couldn't handle it. The stomach was too small, you know, whatever. They weren't getting enough blood to their gut, and so they vomited and they aspirated. Is that a serious adverse event?
Yes, I would say that is a serious adverse event.
Okay. So in a clinical trial, you have to report that, right, to your IRB, right? There's a process for that. What do you do in quality improvement when that happens? How does that get managed?
So for this particular example, we have a multidisciplinary neonatal group that looks at every baby in protocol and would red flag this, and it would be a root cause analysis. Okay. And we would discuss, and if this was a trend, if we saw this happening in more than one baby, then we would look at that protocol again and say, is this the right thing to do or not?
Okay. And would you feel like there's any compulsion to talk to the family about this since they didn't give consent to you for going on an expedited feeding protocol?
That is an interesting point. I don't know if we've ever gone to a family and said, per this protocol, we did this and this happened, but that's a good point.
Yeah, so I put this Tuskegee syphilis experiment up here. I'm assuming most of you know what it is, but I'm just going to pop on it. And I'm definitely not trying to make the parallel between injecting people with syphilis in an unknowing way and doing quality improvement. Okay, so I'm drawing that parallel. That is not the parallel I'm trying to make here. But what I am trying to talk about is it's tricky. It's tricky. And so in our institution, we have a very robust quality improvement infrastructure. And what happens, at least throughout the Department of Surgery, is that sometimes people want to study something, and rather than saying, here's my clinical observation, here's the research method. Oh, I maybe need to do a trial because there's a lot of disincentives to do trials. They say, okay, this is what I want to say. Oh, can I make this into quality improvement? Okay, and that's not quite honest, right, guys? That's not quite intellectually honest, because what you're doing is you're asking a scientific question and you're going to put patients in a group and you're not getting informed consent. And so the Tuskegee syphilis experiment is really what led to the development of the Belmont Report and the establishment of the Office for Human Research Protection. So I'll just highlight it down here so you can see where it is. And it really led to all these federal rules and regulations around protecting human subjects that are involved primarily in trials, right? Because these are sort of prospective things that we're talking about. And I think it would be an interesting exercise to discuss whether there are any parallels between how we were doing research pre-Belmont Report and how we're doing quality improvement right now. And I'm not suggesting that it's bad to do quality improvement at all. I think it's, I'm a fan of quality improvement, but when you think about what a clinical trial is, and we just took a quality improvement project and we put it through a decision tree at the NIH, which suggested it was a clinical trial, and then it is not applicable or relatable to the policies and the procedures and the protections that a clinical trial affords a patient, a participant, a research participant, then I think we have to think about that a little bit. It should make us question some of the stuff that we're doing. Okay, I belabored that point enough. Do you guys have any questions about that discussion, or does anybody want to bring up another point? Please do if you have one.
I get one question I have is, Theta, how you approach that lack of intellectual honesty. And I think I've been in that situation before where I've had people come to me with QI projects, and it's exactly that. It's like they have a research question, or they're not really actually that trained in clinical research, period. And then they try to skirt the IRB, essentially.
Yes.
I'm trying, what's the best way to lead people through that exercise so it maintains that degree of honesty?
Well, that is a phenomenal question. And I too am faced with that a lot, because I get a lot of surgeons who want to study something, but when they realize the amount of input that they have to have into conducting a clinical trial, even if it's a single arm observational study, right? A clinical trial, it's overwhelming to them if they don't have research training. And our quality improvement infrastructure is so robust and accessible, our organization, that it's much easier for them to go the quality improvement route. So I have some questions that I typically do ask a surgeon or some of the medical docs who come to work with us to kind of guide them into that decision making. And you have given me the perfect lead into my next slide, which is, oops, we can skip through it, which is discussing doing a case study and doing exactly that, taking a clinical observation and then deciding if it's QI or research. So I'm going to put your question on hold for about 10 more seconds. Real quick, someone tell me what this is. It's Jeopardy. What is the framework to systematically improve how care is delivered to patients? We just talked about it. Kathleen, what is it?
Quality improvement.
Bam, quality improvement. There you go. Okay. And who here wants to describe the model for improvement and what it is and where it comes from? We've got some experts in this with us today. I'm going to call on somebody if nobody volunteers. Okay, Karina, you're up.
Are we all just overthinking this? Are you just asking about the Plan Do Study Act?
Yes, yes.
Okay.
Not everybody here. Yeah, so if you can, why don't you explain that?
Oh, sure. I mean, I've never actually done it before, but essentially you plan it's essentially exactly what it says, Plan, Do, Study, Act. So you plan what you want to do, you actually do it, you then look and see how did it work, and then you make changes, and you just keep going in that cycle until you end up with your finished product.
Okay, so is it safe to say it's a fairly rapid and iterative process?
Yes.
Okay. Melissa, since you happen to be the fellow probably expert in our group, do you agree with that definition? Anything you want to add?
Yeah, I think that's good. I do want to highlight that this does have its own statistical robustness to it. It does have a question, but I really do think that this hones in on the systems and processes part. So as my protocol is being criticized as a research question. No, I'm kidding. The system and the process is a really big part of this.
Yes. And so Melissa, please don't think your protocol is being criticized. In fact, I wish our single ethical team was doing it here.
Okay.
But it really highlights the gray, and I could have pulled a million surgical examples out. So it just really highlights the gray, but yes. Okay. So if we have a definition of a clinical trial, we have a broad definition of what quality improvement is, let's do a case study in appendicitis, which is exactly what Dr. Ong was suggesting that we maybe do, is try to figure out whether something is a clinical trial or whether it's quality improvement. Okay, this is something near and dear to my heart. I already told you guys that I did it, but let's just pretend that you are in charge of the quality improvement portfolio of projects in the surgical department, okay? And so one of the surgeons comes to you and they say, I think we can decrease disability in children with appendicitis if we treat them non-operatively with antibiotics alone instead of taking them to the operating room, okay? Can we do this through quality improvement? Yes, no, and why? Who wants to jump in?
What's already out there in the literature?
Perfect. That's always my first question too. What does the literature say? Okay, so I'm going to tell you what it said 8 or 9 years ago. Okay, the literature said that had 8 randomized controlled trials that were done largely in Europe, nothing in the United States, mostly in adults, but the studies included some teenagers down to the age of 13 with appendicitis, and they were randomized to non-operative management or to antibiotics alone, and non-operative management was successful 75% of the time. So 75% of the time, the patient did not need to have their appendix taken out. And what they identified in this study is that there were these studies across the board where there were some subgroups that were more at risk for failings, that 25% who failed non-operative management tend to have certain characteristics that set them apart. They had a fecalith, which is like a little poop ball stuck in their base of their appendix. Their white count was really, really high. They were peritonitis. They had peritonitis on exam, or they had pain for more than 3 or 4 or 5 days. So they had prolonged periods of pain. Those people failed. So that's what the data showed.
I would also ask and wonder what's standard of care at the institution that you're practicing in?
Great question. So standard of care at Nationwide Children's Hospital, and I was at CHOP at the time too. I bisected the year when I moved jobs. So standard of care at Children's Hospital Philadelphia, Nationwide Children's Hospital, was every child with appendicitis receives an appendectomy. That was institutional standard of care. Anybody want any more information before they make a decision?
Can I just ask you, this is Katie, I just have maybe a broader surgical question. So, and you tell me if I'm wrong, because obviously I'm not a surgeon, but it's my understanding, and at least I understand, if a surgeon wants to try an innovative way of doing a surgical procedure, so for example, like Dr. Norwood invented the Norwood, or Fontaine, or whoever was, or maybe you want to do an appendectomy in a different way, make the incision on the other side, or I don't know, I'm making something up, but those types of surgical innovation have not always been overseen by IRBs, and so how do you think about where's the line between your surgical interventions that are innovative and on an N of 1 sort of basis, done in a certain kind of way to better the care of that individual and then maybe generalize to other patients? And in this example where you're not operating, could you apply a similar framework?
That's a good question. So surgeons do it all the time. It's like arts and crafts in the OR. And that's probably one of the reasons why there's really not a lot of good standardized clinical interventional trials on surgical technique, because it is hard to standardize and every surgeon thinks they do it best the way they do it. So, so yes, we do innovate on a day-to-day basis, on a patient-to-patient basis. But for me to do something so contrary to what would be the standard of care at my organization does introduce some risk, right? Some liability for me, for my division, for my hospital. So if I were to say, yeah, you know, I'm going to treat this kid non-operatively, and then the kid goes home and develops perforated appendicitis, comes back in septic shock and dies, it's hard to defend. Hey, doc, you know, why didn't you just take the appendix out, right? It's a 20-minute operation. So without that kind of frame of reference, it is difficult, which I think is why it's so important to know institutionally what you did. I don't remember who asked that question, but it's a really important question to understand what you're doing as an institution. And I will broaden that out to say, in this case study, it's what we did as a country. So no one in this country was using non-operative management in routine care. Yeah, we'd use it every once in a while, bridge someone to get home from vacation, to get to the to get to the hospital, to get their operation. The military was using it in submarines or in war zones. They were using non-operative management, but it really was not a part of clinical care in the United States up until recently.
So with those trials that you mentioned, was the standard of care in Europe changing since those studies were based there?
Yes, it was. So Sweden, Norway, they pretty much went to a non-operative treatment paradigm for all appendicitis. And they would, even if a kid or an adult, because most of the studies were adults, would come back with appendicitis again, that 25% would develop it again, they would offer them non-operative management again. So the treatment became, in Europe, in many places in Europe, not just in Norway and Sweden, but even in the UK and in Italy and France, the treatment became treating an intra-abdominal infection. So the same way we treat diverticulitis, tubo-ovarian abscesses, small abscesses for Crohn's disease, the first-line therapy is intravenous antibiotics and conversion to an oral antibiotic regimen. So yeah, people are changing their practice in Europe. And they actually don't understand why the US has been so slow to adopt. I mean, I have my opinions on that, but yeah. Okay. Anybody have any more questions before they want to take a vote?
I don't know if this is a question or if this is a vote, but I'm having a hard time understanding how this individual who wants to lead this doesn't think that it could contribute to generalizable knowledge, or that's not their intent. Like, it sounds to me like they have a question that is independent of the local context, which is basically, does this treatment work as well as another treatment? And so to me, it just doesn't sound like, seems like it would be hard to make the argument that you're not trying to contribute to generalizable knowledge.
Very well. Yeah, very well stated. I agree with you. And that would be your vote then. You would say this person needs to do a trial.
Yes, it doesn't seem like the local context is all that important in this case. And maybe I'm missing something, but.
No, you're not. Okay, so how would you, and let me follow up that, answer your question with a question. So how are you going to tell this investigator what to do?
I would explain the difference between QI and research and.
Okay, explain that.
Right now?
Yeah, right now.
Okay. I would say, I mean, I would basically use the definition of, I think I would focus on the contributing to generalizable knowledge. I mean, I think either can be systematic, but one intends to investigate or evaluate changes that could contribute to generalizable knowledge sort of outside of the local context, whereas one is really focused on changes in practices or processes within a local context, and explain why this, at least this is a very gray zone. But to me, it seems like it would contribute to generalizable knowledge. And I also think I would just ask them to explain what their what they see the purpose of the study as being, and then explain that it would need to. I mean, at our institution at Nemours, it would have to go to the IRB either way. So it would go for research determination, and then very likely the IRB would determine that it is indeed human subjects research and would ask them to submit a full publication.
Yeah, I agree. I would also say not even just the local context, but for me, this really brings up that issue of informed consent.
Mm-hmm.
Right? Because you're now doing a treatment that is outside what would you call standard of care, which is a legal term, but the standard of care at your organization and within the country. And so to me, that feels like science. And so that to me would indicate we need to get informed consent. So I would talk to the investigator about that. That's what I would tell a surgeon. I feel like we probably need to get informed consent. What do you think about that? How are you going to explain to the family why they're not having surgery when you haven't talked to them about giving them a choice for surgery or not? So
can I ask a question?
Yeah, please. Who's talking real quick? Because I can't see you guys.
Sorry, it's Theta again.
Okay.
Is it because I'm kind of voting in the realm of trial because, as you said, you don't have the clinical, like the buy-in of what the standard of care is, and so you need the added protection and rigor of the regulatory bodies and whatnot to help guide your actions. But I guess then, is it just a state of the current context, meaning like if we did this, if this was the same question came to be in Europe at now where it's a more embodied state of practice, can the exact same question become a clinical become a QI project because you have more buy-in from the people around you? And so really we're just like limiting because we don't have the same structures of regulation and protection with regards to improvement. So we don't want to, it's like time and space that have sort of separated us because we sort of locked ourselves into the IRB, and having that as a fallback to give protection to the subjects for the work that we want to do.
Yeah, I think you're right. I'd like to hear anybody else's comments with that, but I agree with you. Yes, you're right, 100%. And a lot of it is contextual.
I mean, like
a lot of
the data, right?
Charles, is that you?
Yeah, like
okay.
We look at these graphs that show that scientists figure things out and it takes 20, 25 years to reach clinical practice. Like how much do I need to be convinced to do something? Then, and the question matters, right? Being a little glib about it, but if somebody's figured this out and done a really good job at it, and I'm trialing it clinically, that's one thing. Am I planning to make a registry and talk about this later? This is one of those scenarios where it always just reminds me of how do you know the difference between art and vulgarity? And like, you kind of know it when you see it. Sometimes this falls, like it can be hard to really strictly define these things. You're doing a great job bringing up the ambiguity between all of this, but.
Yeah, and I can't define it for you. I'm not going to define it for you, but you're right. I would say, let's not get pinned into a single definition of what a trial is, right? The NIH definition was broad. So when we decided we wanted to study this 12 years ago, I had no desire to study this with QI. I actually wanted to do a trial, but I felt like the 8 randomized controlled trials that were done in Europe were probably sufficient to establish the efficacy, the safety, and the efficacy of the therapy. Okay, so it was being used. Kids were not, when it pulled out all the teenagers from all the studies, kids were not being harmed, and it was successful. Okay, so those randomized controlled trials showed that. That's what randomized controlled trials are designed to show you, safety and efficacy. But the question for us was really around how do we apply it more broadly and study it more broadly in the environment of the United States, which is actually very different than how care is administered in the European countries where these trials were being done. So for us, it meant, okay, we need to do 2 things. We need to do a more pragmatic trial. Like, let's create a decision tool to help families make a decision of which one is more aligned with their preferences, surgery or no surgery. And then let's throw it out there across 12 children's hospitals and see if the rates of non-operative management success change, and see like who's choosing it and who's not choosing it. So it was a different kind of study. And then the second study was a randomized controlled trial, but it was based on using a formal decision aid in like an application. It was called a activation tool. So it was an application that we did on iPads. And the reason we chose those is because we're going to talk about this with pragmatic studies, but when we decided we didn't need to do any more efficacy work, our goal was how do we implement and how do we study it in our American context. We took it to stakeholders, right? I mean, you guys know about PCORI, so I don't need probably to explain all that, but we took it to stakeholders who said, please don't do another randomized controlled trial. Please give us a choice. This is what the families were saying. Give us a choice. This might be the right thing for our kids. So we designed a trial based on stakeholder feedback, which is part of the pragmatic trial design process. So I think you bring up a really good point there, Charles. Let me, so we did this. What information do you want to answer? What are your thoughts around informed consent? We didn't really talk too much about that, but would you guys agree or disagree that you need to have informed consent for this? I said you did.
Agree.
Okay, looks like most people are nodding. Okay, and then this is something we sort of addressed prior. Melissa helped educate us on how this would happen in her quality improvement project, but how you would handle adverse events and serious adverse events with these different methodologies, and that's important. Okay, so here's the big question. Has talking about clinical trials in this context related to QI, has it confused you more or clarified things? I know what it's done for me.
Confused.
Absolutely, it is confusing and it is gray. And this is my job in talking to you about clinical trials. I actually, and Chris probably disagrees with this, but I'm not here to bring you clarity. I'm here to stimulate discussion, to try to help you think about if what you're doing falls within a clinical trial framework or not. And if so, what are some of the tangible steps you need to take to protect research subjects if they're in a clinical trial, and some of the regulatory stuff you have to do. And that's all on that website. So the link to the NIH, you could use that if you were thinking about that. So I feel like we understand the definition of a clinical trial based on this discussion. I think we've talked about its implications and applications. I don't think we brought clarity to it, but that wasn't part of the learning objective very intentionally. So is everybody ready to move on to the next learning objective, which is talking about pragmatic trials? Anybody have anything else they want to say about the first learning objective? You feel learned? Okay, so let's go. What is a pragmatic trial? This is just from a textbook chapter that I wrote on pragmatic trials. They're trials designed with an emphasis on using a treatment in clinical practice. They investigate a treatment strategy that can be implemented in the usual care in a diverse patient population. They incorporate the perspective of stakeholders, including patients, clinicians, and healthcare systems, and are designed to generate actionable and relevant results that can be used for clinical decision making. So some of the key things that pop out in this definition are putting these trials in usual care, okay, and studying usual care, implementing them in a usual care, standard of care practice paradigm. Making sure we have the perspective of stakeholders, and we've engaged various stakeholders. And the term stakeholders over the last 10 years is now just like thrown around a lot. It was very like a very novel term when PCORI came out. But when you think about a stakeholder, the best way to know who to put on your stakeholder team is to understand who are the end users of what it is you want to study. So in our example on appendicitis care, I clearly wanted patients, and I wanted parents, and I wanted teenagers who, like older teenagers who are their own decision makers. I wanted all these people, patients and children, patients who were of different socioeconomic statuses and different race ethnicities, and represented people who spoke the languages that are most commonly seen in our institution and in throughout the Midwest, actually, because we did it across Midwest hospitals. You also want to have, who else are end users besides patients and families? Well, it's surgeons. I need other surgeons who have a different perspective than me. Emergency medicine docs, because they're the ones seeing these kids come into the emergency room, and so they're definitely going to have an opinion on how to have that conversation about operative versus non-operative management. Nursing staff. So nurses from the entire arc of care associated with appendicitis care, from the ED all the way through surgical follow-up, because each piece, each touch point for these patients is important, and it's good to get the perspective of those people who are working with the kids. Payers. So we have one of the largest accountable care organizations in pediatrics here in Nationwide Children's Hospital. It's called Partners for Kids. I happen to be the vice chair on the board, but at the time, I couldn't just use myself as a stakeholder. So I had the chief medical officer for Partners for Kids be a stakeholder on our team. And then we had a representative from United Healthcare, who was one of the big payers locally and also throughout the Midwest as a stakeholder. We had physician educators as stakeholders. So it really just depends on who the end user is of the data that you're going to generate from your study. You should think of them as stakeholders. And then, of course, they should be designed to generate actionable and relevant results. So you see that figure on the bottom. Explanatory trials are that, think of the really traditional efficacy study, the randomized controlled trial of a particular medication versus a placebo, right? Medication work in a very ideal condition. The pragmatic trial is not so much that. It's, does this intervention work in usual conditions? So a great example of something that can be studied in a pragmatic clinical trial, and Charles, you may know of some of this work, but is around the use of dialysis versus medical management for chronic renal failure. And specifically, if you studied it in a quaternary hospital, dialysis is probably going to come up the winner every time, okay? But when you broaden that population out that you want to study to the rural demographic, to people who don't have good access to care, whether it's because of where they live or the language they speak or whether they can pay for it or not, that decision and the results of that study may look very different when it's applied to a broader population. So a pragmatic trial is really talking about, does this intervention you want to study work in the usual conditions? So in the appendicitis study, that was important for us because we didn't want to tightly control everything. We didn't want to have all the surgeons following the same protocol, kind of always having it in their face that they need to be offering non-operative management. We wanted to throw it out there into general surgical practice and assess it there. Okay, so here's, I'm sorry, my computer's about to die, so I'm going to just need to move this over real quick. Sorry, guys. So here's what a pragmatic clinical trial is, okay? Designed for the primary purpose of informing decision makers regarding the comparative balance of benefits, burdens, and risks. It occurs in usual care locations. It utilizes existing clinical infrastructure, operations, and personnel. It has minimal eligibility criteria in order to maximize recruitment and generalizability. Delivery, follow-up, and adherence are aligned with what current practice is. And it occurs along the spectrum, some trials being more pragmatic than others, which really, I think, makes sense. So based on this, what do you guys think are some of the perceived advantages of a pragmatic trial design? And what do you think are some of the challenges of implementing a pragmatic study design? In your own words. Charles, you go first.
Oh.
Yeah, I just think I like the strength being that it's been applied within clinical care. So like the things that get in the way over in healthcare that you can try to get away from in a randomized clinical controlled trial where everything's very well managed, those things create a little more friction, I would think. So you can see more of a real world effect from a strength.
Mm-hmm. Yeah, challenges. Like what would you think would be some of the challenges related to that?
I mean, I've only ever trained in Cincinnati, and though I know how my system works here, at least I think I do, right? It's hard. I wanted to tell you about this great thing. I'm like, look, it works. It's applicable. Look how we did this. And you're like, we don't have these, I don't have X, Y, and Z. I don't have these things. So it's really not that generalizable. So you have to be really intentional, I would think, from how you design that to make sure it truly is generalizable.
How do you statistically power something like this where it isn't so pure that everyone is following a very structured design protocol?
Okay, well, why don't you try to answer your own question? How do you think you do it? Like, how do you power a standard randomized controlled trial? Like a placebo versus treatment. How would you power that?
You would have to know like the proper sample size to get your desired effect.
Yeah, so what do you need to know to get your sample size? You sort of said it at the end there.
Like the effect rate or?
Yeah, your presumed treatment effect, right? And how do you get that? Like if you haven't studied it yet, how do you know that? How do you know what it is?
I always struggle with this. This is probably why I do quality improvement work.
Yeah, no. Yeah, I mean, it is hard, right? Because it's like, it's kind of a guess. It's like an educated guess. I can tell you what I do. I go to the literature and I look at the rates of disease and how it's penetrated into the environment in which I want to study, and if that's been changing over time. And I just find some evidence to back up those values. So when in the appendicitis study, when we had to power that study, we looked at the success rate of non-operative management. And so we knew that it was 75% successful in other trials and also in observational studies. There were a lot of other observational studies that have been done at that time too. And so we used other studies to power our study. Yeah, so you turn to the literature primarily for that. Anybody have anything else they want to ask or contribute on that? Okay. So, I mean, this is just, I just put this together because these are things that I think about. And it's one of the reasons why I love pragmatic studies. But when you think about an explanatory study, so least pragmatic study possible, it's highly, highly controlled, right? So what does that look like in the day-to-day? You have research staff that are blinded. You have a research nurse that's doing recruitment. You have specific people giving consent. They're using a script to get consent. Let's pretend it's randomized. So if it's randomized, the randomization process is also pretty tightly controlled and monitored and solidified early on. Safety monitoring. So how you're going to monitor safety is controlled and measured in a specific way with certain people assigned to do it. And there is a little bit of a less complicated statistical approach because you're tightly controlling everything. And so you can kind of presume that the biases are going to be less, and you can probably assume that the error around that treatment effect is probably, so the standard deviation around treatment effect point estimate is probably going to be a little bit tighter. When you're in a pragmatic trial, you're looking at less control, right? You're sending something out there. I mean, look at the study we're about to talk about, adaptable. They're sending something out there across 15,000 patients, right? We did it, our appendicitis stuff was across 12 hospitals. So yeah, I have some kind of research staff sort of in those locations, but it's not the same person getting consent every time for being a part of the study. It's not the same person that's informing them what is non-op management versus what is the surgical approach. So you can't really control it as much. Now you could control it more. You can put a lot of things in place, but then you're shifting yourself out of the pragmatic trial design towards the explanatory trial design. And when you do that, you decrease the external validity of the study. So I think it was Peter talked about this a little bit last week, but someone talked a little bit about internal versus external validity in studies. And so in internal validity, does anybody know what that means? Let me just ask you guys before I launch into the definitions. Anybody want to describe internal validity versus external validity? Okay, so internal validity says, oh, sorry, go ahead, please. Yeah.
Oh, sorry. Internal validity is really about, are you decreasing bias so that you can be sure that you're measuring what you intend to measure, that what you intend to measure is clinically meaningful. So really about like reducing sources of bias that enter your study. External validity is more about, does your study generalize to other contexts? Can you apply what you've learned to other places or other settings?
Yes, that's great. That's exactly what it is. I think of internal validity as when you have a study that's tightly controlled, okay, then it is, the results of that are likely to be highly reproducible if placed in the exact same environment again, right? So to me, that's not super real world. So I think external validity is, yeah, this is not a fairly tightly controlled study, but because the results, because the study was done in a more heterogeneous population, a greater range of settings, had less protocolization of the intervention or the follow-up or whatever, how something is administered, then that's going to be more reproducible and it's more likely to be meaningful when applied within a context outside of a study context. And so one of the big concerns around tightly controlled, highly internally valid, randomized controlled trials is that, you know, you publish them in the New England Journal and then wait a minute, nobody's really doing it, right? Why hasn't there been an uptake and an adoption of these recommendations in clinical practice? And there's a lot of examples out there where people have gone in to study that, and what they found is they can't adopt them into clinical practice because it's really hard to do. So for whatever reason, maybe they don't have someone who can administer the procedure or the protocol, or maybe there's some physiologic parameters around patients that aren't quite exactly what the study was, the intervention was meant to apply to. Or maybe the population in your organization is totally different than the population in which it was studied in. Some of you might know this, some of you might not, but women have, and females have typically been very understudied in clinical, in all of research, but primarily in clinical trials. And this is like a bit of a hot item in surgical research because there's a lot of recommendations out there around cardiac revascularization and vascular procedures like in carotid arteries or distal bypass procedures that are all based on studying middle-aged and older middle-aged men. And what they found is that when those recommendations from these trials have been put into practice, women don't do well with those interventions. And that's kind of, and so there's been some blowback on, well, the trials were essentially not pragmatic, right? They weren't studied in the population in which the intervention was going to be recommended for. And so that's one of the issues that you see around internal validity and external validity. It's really about the generalizability of your results. So yeah, so you nailed it.
Can I just ask a question about sort of the study design portion? So one thing I was thinking about is, what about taking the approach of a pragmatic approach to a sort of a pure clinical trial? So you design it in a rigorous way with all of those internal validity checks, but then you might analyze things in a pragmatic way. So you might do things one way where you're looking at how you look at your intention to treat and your protocol analyses, but then you also look at it from a pragmatic perspective. So now you're including folks where maybe some of those you're thinking now outside the inclusion-exclusion criteria, for example, or maybe you're incorporating some folks who underwent clinical care, which also overlapped with your clinical trial design. So how I guess accepted is that approach sort of in the medical world that does pragmatic trials?
Yeah, I mean, it is accepted. It's really about how you design it and then what type of analysis you put. And by the way, right, your analysis, your statistical planning should always be done at the onset. What your analytical approach is going to be with that degree of looseness around the design. Yeah, but you can do it. You can definitely do it. Did that answer your question, Suchita?
Yeah, thanks.
Okay. I just looked up at the time. We have 8 minutes, so, and we're only on learning objective 2. The next question I had for you guys, which is, which of these features do you think is most important and why? I'm going to bypass it because I'm going to tell you my answer is around internal and external validity. We just sort of talked about that, and I think we kind of exhausted that. Is that all right if we keep going? Anybody think they want to say? I see nodding. Okay, let's keep going. All right. So Charles, calling you out. We're going to get this quick. We're going to spend 3 minutes on this slide max so we can get the learning objective number 3. Tell us about this adaptable trial. What was the trial?
Oh man. I had some stuff that I wrote down, but I'm not able to pull it up.
No, don't worry. Here, look, I'm helping you. Are you ready for this? Go ahead. What is the trial?
Let me tell you how my brain synthesized this stuff that I don't think about very often. So it seemed to me that there was a research question that was put out there. They wanted to figure out about which dose of aspirin worked better for people to reduce whatever their cardiovascular outcome was. But with different points along the way, they would kind of like sneak a peek at the results and see how things are looking so far, so that you could you could change your allocation groups, or you could a priori decide if things looked a certain way, you could make a change like during the trial, which was written in such a way that I guess sounded smart. Like people were thinking quite a bit about it to do it the right way and not in a biased way.
Okay.
And
So I didn't see that in the adaptable trial. I didn't see that adaptive part of the design, but perhaps I missed it.
I could be thinking about this other paper. I read the 3 of them all at the same time. So
yeah, and that adaptive one is a brute to read. So yeah, so the adaptable trial really was randomizing patients who were at risk for secondary coronary events to either low-dose aspirin or high-dose aspirin. And they felt like they had equipoise to do this randomized controlled trial because there has not really been any data to show that one dose is better than the other in terms of preventing secondary events. And so what was interesting about the adaptable study is they wanted to do it in a way that was innovative, right? So it's not just like, okay, I get 15, 20 hospitals together and we're going to do this trial and it's going to cost us like $30 million because we have to have trial personnel at every organization and a huge DCC and all this stuff, right? They had an innovative approach to how they wanted to do in a randomized controlled trial in a learning healthcare system. So what were some of these innovative approaches that they used? What were the methods for how they did this? So Gina, can you, do you have an idea? Were you able to read it, the study?
Yeah, so some of the approaches, I guess, that they used that were slightly different from the usual clinical trials were some of their recruitment methods. So they were utilizing the PCOR network and then developing these computable phenotypes where that would help them with determining who would be eligible for the study, and then reach out to them sort of electronically or to see if they would be interested. And then their consent process was definitely different from their usual, from the usual clinical trials where they were done online through a web portal.
Yeah.
And then just trying to think through some other things.
Well, yeah, so you talked about recruitment, right? So recruitment was done through what? What is this thing that you guys have already learned about? But how did they recruit? They didn't like just call people, right? They use some coding, some IC9, IC10 codes initially to come up with a computable phenotype, and then they search for that phenotype across the organizations. And they didn't just say, here's one way to do it. They said, okay, here's a way. And then they told the organizations, okay, but in your local environment, how can you take the definition of what we're looking for and build that phenotype in your local environment, right? And so it was really, really smart and pragmatic because it allowed each of the institutions to have a little bit of a homegrown method with sharing of ideas. So, but it was controlled in the sense that they had a very defined patient population that they were looking for. I feel like I heard you say all those things. And then you talked a little bit about informed consent, right? And that was electronic and that there was a web portal for it. So it wasn't someone having to find a patient and sit down and go through paper forms, which is very laborious. It was all done through a web portal. So very, very innovative to do that. Not something that's been done a great deal to date in randomized controlled trials or in large pragmatic trials. Okay, and then what else? There were some other things around randomization. So let me pull down here. Here it is. Direct-to-patient randomization. Right, so all the visits were including a randomization visit, were sort of virtual visits, and they could be completed in the web portal and didn't require any clinical touch points, right? And then what about follow-up? How did they get all their data? Like, how did they get all this follow-up data? What kind of innovative strategies did they use there?
So I think some of their follow-up was done through these web portals and then through the call centers, depending on what each site was thinking about. But then they also did a lot of their data collection methods using the EHR for endpoint ascertainment and for other endpoints they were looking at.
Mm-hmm.
And then there was something about...
I'm sorry, go ahead.
I think even with certain information regarding mortality, I think they were looking at death registry data as well.
They didn't do death registry because there were some issues with it, but they linked this data to claims data. So such a great idea, right? Because your claims data will tell you if you have an event, whether it's death or hospitalization or, you know, a new medication added or a procedure like a cath or something at a hospital which is not part of your LHS. So if, you know, one of these guys is traveling down to Florida and he has his angina when he's in Florida, it's still going to get billed through Medicare. So as long as they have the claims data, they're going to be able to capture that he had an event while on study. So they were collecting data from somewhat disparate data sources and bringing it together to be able to measure that. What else? Anything else?
Wasn't this the one too where they gave you the dose and they were like, you got to go get it, go get your medicine and take it on your own and do a good job kind of thing?
Yeah, so okay, well, yes. So that's very pragmatic, right? Because, you know, how many people don't finish their medicine, right? Take their medicine every day. So, okay, so you bring up a really important point, Charles, which is about adherence. Did they do anything to look at adherence and whether people were taking their meds or not? No, they didn't. So, right, it would be impossible to have every single pharmacy linked with those caps that, you know, are able to, the smart caps are able to tell you whether you took your med or took your med out of the bottle at least every time you did it. So there is an example of how a pragmatic study like this, it's less controlled, but more externally valid. So it's a really good example of that. Okay, anybody have anything else they wanted to say about the adaptable trial? Because I'm just gonna talk about one thing to sing its praises a little bit. Okay, so only thing I also wanted to say about the adaptable trial is in their discussion, they talk about it as being a demonstration study that would be a benchmark on which iterative improvement of a pragmatic method could be developed around recruitment and retention and endpoint ascertainment using pragmatic studies in learning healthcare systems. And I think that it's just amazing. It gets me very excited. I'm so excited to find out what the results of this study are, primarily from a methodologic standpoint, because it'll be applicable to my own work, and I think it's really going to advance the field quite a bit. So I want to just ask Chris if he's on the line real quick so we can wrap up the adaptable stuff. They're supposed to have data out June 2020. I emailed one of the co-Is. I did not hear back from him. Do you have any estimate for when their data is going to be out, or if the trial's done?
Okay, Chris, I'm sorry, were you asking that to Chris?
I was.
He had to drop off because he had to unexpectedly lead a call, but I can follow up.
You don't have to. I really wanted him to see his face next to Willy Wonka. That was kind of my goal for the slide. So that's okay. That's all good.
Okay.
So you guys, so we kind of do have to wrap it up. So give me just 1 minute to fly through a couple things. And I really want you to think about, if you're going to read any single article from this or think about any particular issue in this talk, please read the adaptable study and how it might apply to the design or conduct of trials in your own field. You guys are all doing some really impactful work within the context of your K awards. And so your next step are going to be these R's. And man, trials are the best. It's the best field to get into. And so I just would encourage you to think about it. How whatever you're studying could be applied in a learning healthcare system in a pragmatic trial. So adaptive trial design, real quick on this so we can tick off, or at least partially tick off learning objective number 3. Basically, an adaptive trial design is a design that allows for modifications to the trial or the statistical procedure during the course of the trial without undermining its validity or integrity. Wow, that's like a big lift, a big ask. And so you can have a trial that's adaptive in terms of changing eligibility in the middle of the study, changing dose, duration, or treatment group, changing endpoints, changing study procedures, changing your criteria by which you're going to evaluate the clinical response of a treatment. You can also change some of the statistical procedures, how you randomize, when and how you do interim analyses, okay? All these things in an adaptive trial design, you can change one or some, but the key thing is in an adaptive trial design, you have to pre-specify that you're going to do this as part of your design, okay? So just put your attention to the right of the screen. This response adaptive randomization method combined with a drop the loser design. Okay, here's just an example. On the right of the screen, within that figure, on the column on the left, a trial was started that had 5 arms to it, okay? 4 which were treatment arms and 1 was a placebo. And what happened is during interim analysis, they found that the group that has the second from the top, let's see, I pointer to work here. Yeah, this one right here was actually showing either benefit or harm, but probably benefit, okay? And this one was showing benefit. But there really wasn't any difference in treatment between this group, and placebo. So what that enabled them to do is to change how they randomized. So in the groups that were actually having a response to a treatment, they started randomizing in a 1-to-3 ratio instead of a 1-to-1. So there would be 3 people put into this group for every 1 that was put into this group, every 2 that was put into this group. And so you're kind of like stacking the groups. And then what that leads to is if you have an inferior arm, so an arm of the trial that's not performing well, or maybe even you're seeing harm at a particular treatment or lack of efficacy in a particular dose of a treatment, you drop the group. And so by dropping the group, which is called drop the loser design, you're increasing the amount of patients that get randomized to the group that's looking like it's going to win the race, okay? And so then you end up with a 1-to-1 randomization sort of at the end between 2 groups. So it enables you to drop treatment groups. So this is a very appealing thing conceptually because it's really good for resource utilization, and getting to an answer quicker. But there's a lot of statistical modeling on the backside of it that you need to be very facile with. And the bottom line is if you want to do anything that's an adaptive trial design, you have to get a statistician involved who is very experienced with a Bayesian approach for their analysis, okay? Because a Bayesian approach, really what it does, the bottom line, is it allows you to account for new data in updating probabilities, which is very different than the frequentist approach. So we don't have time, so I can't get into this, but I did not even want to get into it because it's like asking someone what's better, the Red Sox or the Yankees, okay? It's such a heated conversation amongst trialists. People who are frequentists, who like the traditional statistical approach, they have very, very intense opinions about people who support Bayesian types of analytical approaches and adaptive trial designs. And the converse is actually true as well. The bottom line is when you're designing a study, you have to think about what methodologic approach is most appropriate for your research question, and then take into account how many patients you have that you can study with it, the toxicity of the intervention you're studying, and you may find yourself having a conversation with your analyst, with your statistician around, hey, maybe this should be an adaptive trial design. And if you get into that conversation, then there's a lot of good advice there on the methodologic standards you need to use to do those kinds of studies. You can go to the PCORI website. These are hyperlinks, so you can access them, and you can go to the FDA. Those are the 2 sort of big U.S. federal organization, of course not really federal, but U.S. funding agencies that have really good detailed advice on what you need to do for adaptive trial designs and clinical research. So I think we hit learning objective 1. I think we hit learning objective 2. I'm not sure we hit learning objective 3, but I had sort of stacked the odds against learning objective 3 happening anyway. Do you guys have any questions for me?
I just have a really quick one. Is the adaptive trial design that you discussed, is that the same as the SMART trial approach? Are they both the same thing?
No, I don't know that actually. I don't know what that is.
So it's an acronym. It stands for the Sequential Multiple Assignment Randomization Trial.
Oh, okay. So no, that's different. That's you go from, that's when you change the group you're randomized to. It's a treatment group change. It's not dropping treatment groups. Yep. Yeah, there's a lot of different adaptive trial designs, which is why rather than naming them, I just put all the things you can change. Because for each of those things, there's like 3 or 4 kind of colloquial terms used around the labeling of the kind of trial that it is. Yeah, flexible trial designs is another term that's sort of broadly applied. So if you guys have any questions about work you're doing, you want to know, you're thinking about designing a trial, you want some advice on what your next steps would be to take whatever your body of work is towards a trial, I am happy to help. Just reach out to me by email. We can set up a one-on-one meeting to discuss your particular project. If you have any questions about any of this stuff in the reading, please don't hesitate to reach out. I hope you guys like this way of doing it. I know it's hard because I put you on the spot a lot for the MDs in the group. I know you're thinking about your surgical rotations and like, oh my God, she's putting me on the spot like in the OR. But I do think it's the best way that we learn, and I think everybody did a great job answering questions. So I really appreciate all your input and your participation.
Thank you, Kate, so much. It was a really great, engaging session. I feel like we covered a lot, and I'd love to send out the hard copy of your slides, if that's okay, so that they
Absolutely.
can look at your material. So thank you, everyone, and thanks for staying on a few minutes extra as well. So take care, and we'll see you on the next session. Thanks, everyone. Thank you, Kate.
Thanks, guys. Be safe.
Bye.
Bye.
Bye-bye.